Cancer would be the uncontrolled growth of cells in the body. So that's kind of what we would define as malignant. It's not just that the cells grow out of control, but they also behave without any control. They go places they don't belong, and that's kind of the difference between a benign and a malignant tumor. Benign tumors don't spread, but malignant tumors do and destroy tissue as they progress.
Cells undergo changes, and these changes can lead to really an uncontrolled growth. So when there are changes on a molecular level in a cell which are caused by everyday accidents, radiation, sunshine, food we eat, things we inhale, and these cells accumulate these damages, and these damages can lead to a certain threshold where this cell does not anymore behave in a normal pattern.
But the reason it's so difficult to treat is because it evolves. The cancer is almost like an organism. It's almost like a living organism, just like human beings. It has the ability to adapt to its environment and to evolve and to develop defense measures and things that can keep it from, being susceptible to treatment.
Because every cancer is different. Even when you have one gastric cancer or one colon cancer or one liver cancer, it's not the same disease. And the cancer itself is populated by millions and billions of cells, and these cells are distinct from one to each other. And just to find one fits-it-all chemotherapy for this cancer rather than for every patient with the same cancer is impossible and will never work.
I guess we could break it into two categories. One is patients with a genetic predisposition. The other is patients who have an acquired propensity for cancer because they've been exposed to carcinogenic substances. So the most common in that latter group would be tobacco, and the risk of not just lung cancers, but throat, esophagus, bladder, an array of other cancers, not to mention the vascular disease. Genetics is probably a big area of interest right now. A lot of people are aware because of celebrities in the news about the breast and ovarian cancer syndromes. So we actually have a growing interest in medical genetics, and Cedars, for example, has a genetics risk program, and we've got some full-time physicians that's their specialty. I mean, we kind of dabble a little bit, and then there's a lot of private companies that will do some gene testing. Now with the advent of the ability to sequence the genome very quickly and at a decreasing price, we're able to kind of identify patients who might be at risk, and obviously more cancer syndromes will be able to be identified, and therefore hopefully better screening in more targeted patient populations will lead to earlier detection and better outcomes.
Well, colon cancer is a wonderful example. If you do screening, you prevent colon cancer at 100%. Now, gastric cancer, since the incidence in the United States is relatively low compared to Asian countries, in Asia, gastroscopies, appendoscopies are part of their screening, and they detect gastric cancer so early and prevent metastatic disease. So that is already shown to be possible. Now, there are organs which are very difficult to screen. For pancreas cancer, very difficult. Ovarian cancer. But screening for liver cancer, again, very easy. If these are screened and detected early or early precancerous lesion, you can successfully prevent this disease.
Patients with advanced cancers sure will have systemic symptoms, fatigue, pain, weight loss, maybe some low-grade fevers, just feeling ill. Obviously, somebody with lung cancer, maybe cough, shortness of breath, maybe colorectal cancer, change in bowel habits, bleeding, things like that. Breast cancer, women come in with it, maybe because they found a lump in the breast. Hopefully you find these diseases when they're localized to the organ that it started, rather than when it's spread through the body, which makes it, a lot tougher to treat.
So clinical trials are absolutely essential. It's part of the 3 C's: cancer, clinical trials, and cure. Without clinical trials, we will never advance new treatments. And there are different phases when we develop new drugs which are promising in the preclinical settings, mouse models with the same cancer. If we put it for the first time into the clinic, that's a phase 1 trial. We still have no understanding how much drug do we have to use, what are the toxicities, but we already see potentially efficacies. So from the first trial, phase 1, where we're understanding the side effect profile and proof of principle, we move it to the phase 2, which means we test the efficacy of this drug in different cancers. And the next level is to make it sure this drug is effective or more effective than the standard of care to get it approved.
With the advent of gene testing, in fact, where it started is going to become secondary. What we're really going to want to know is what's the gene profile, so which targeted therapies are we going to pull off the shelf to shut down this malignant disease.
I think we're in the middle of a molecular revolution. It's an extremely exciting time, and I think we are making more and more progress. I think what we all realize is this is a global challenge and not an issue of a university or a country or a state. I think we are forming major alliances around the world to solve this problem, that cancers is even one specific cancer is not one disease. We're going to dissect it out in many, many different diseases and individualize on this. I think it will be a challenge for the society how we maintain funding to really understand and move forward treatment strategies which are designed for very few patients. Can we afford it, and is it feasible for healthcare providers? So I think we need really a global approach in order to make this a successful strategy. I have no doubt we will, and we will cure colon cancer or any GI cancer in the future. It doesn't come fast enough.